20 years of service by the World Surgical Foundation. How do we measure success?
I'll pull this up for you. Oh, I got it. You probably would have done better at this than me.
Super.
Thank you.
Go on.
If I go a little over the time, please forgive me because this is a very broad topic. So I tried to really reduce it to the time. It was very difficult. So I'm gonna do it quickly and hopefully be on time. But since we have one speaker who's not coming, maybe I can steal a little bit of the time.
What is because the last
First of all, I have nothing to disclose. So I want to give you a little review of the global burden of surgical disease. Everybody, some of you have heard this before, and that is there's 11% global burden of disease attributable to surgical conditions. And you can see trauma, malignancy, and I'm a pediatric surgeon, so congenital anomalies is close to my heart. Of course, you can see complications of pregnancy, perinatal conditions, and now you also have cataracts, a big problem. So we need ophthalmologists to volunteer, but I have difficulty getting the ophthalmologists to get out of their practice because they're going to lose money. And also, the younger ophthalmologists don't know how to do the old-fashioned way, so it also comes to become a difficult problem. You can see also here that the mortality for trauma is much higher than HIV, TB, and malaria combined, and all the other infectious diseases. And yet the funding for surgery is still minimal throughout the world. And I can tell you the reasons why. In 1980, during a meeting, the ICS meeting in Mexico City, actually Dr. Halfdan Mahler, the director of WHO, said that surgery was important for basic care, and that his goal was that by year 2000, we would have solved the world's problem for surgery. Guess what? That hasn't occurred. The barriers for the global surgical needs are many, and as you all know, that the WHO and the WHA recognize surgery as an important component of primary global health in 2015. And then 2016, they formalized it, and they're still talking. There's still discussions underway. I know there are many organizations like a G4, et cetera, but again, there's no funding. They're still talking. And the NGOs, big NGO funders, have not funded any surgical initiatives. So we need, as a body, to try to, convince them that indeed it's important. We don't have enough surgeons, anesthesia providers. You have to always include anesthesia whenever you talk about surgery, because you can have 100 surgeons and you have anesthesiologists, you can't do anything. It's very important, extremely important. You gotta have anesthesia. And it should always include anesthesia and your global needs. If you don't have anesthesia, you can forget it. Doesn't work. There you go. I have one anesthesiologist who's saying hooray.
I already knew that, Dr.
And also the healthcare expenditures in low-income countries and middle-income countries is less than 2% of GDP, sometimes even hardly any, compared to what we do in the US and the Western world. There are other barriers to the access for healthcare, and you can have political and economic turmoil, which we see, military conflicts. There's disparity between the rich and poor, and all the maldistribution of doctors, and they're all also underpaid and overworked. So it's a very difficult time. Just to give you an example, where I go to Honduras many times, the surgeon for him to earn $44,000 equivalent in a year, he has to work 6 hospitals and drive around like crazy and work 24/7 almost. Can hardly see his family at the end, and they don't make that kind of money. The ratio of surgeon to population is also very difficult. You can see in Africa, 0.5 surgeon per 100,000 population compared to the US with 65 to 100,000, and then similar to other countries as well. We also have 6 major surgical challenges. And again, I see here anesthesia management, airway and anesthesia management important. You talk about trauma, all that. And then from my perspective, pediatric surgery is very difficult because there are not enough pediatric surgeons. And then the post-operative pain, we talk about the opioid problem we have here, but in the other countries, they don't give anything. They're all screaming in pain. And we were just coming back from Nigeria, and the nurses were yelling at the patients for having pain. And we have to buy the pain medicine, and when we go to their pharmacy, they don't even have narcotic. They don't even have the narcotic for us to buy, to give our patients. So we have to kind of smuggle a little bit of fentanyl every so often, and we get a lot of Toradol. Of course, natural disasters, you mentioned about tsunami. This can affect the delivery of healthcare, and that happens, and our world is in turmoil. You can see a lot of natural disasters coming up soon, and you've seen the earthquakes and the volcanoes, the flooding, etc., and the typhoon, which I won't discuss here because that's another topic in itself, how to take care of people in a disaster area. We won't discuss that today. So what we do, our foundation was formed in 1997. It was a concept that I felt that, because when I went to these missions with other people, with other groups, although I provided service, they were happy, they felt good about it, but I didn't feel good. So I feel that a lot of the short-term missions are feel-good missions, but I didn't feel good. I felt lousy at the end. So I said, something's wrong with that idea. So you should do something else. So you should make it sustainable. You have to teach. You have to give them equipment and supplies. You have to support them somehow until they can be on their own. And that's what we've been doing over the last 20 years. And people ask me, why do you do this? I don't know. I have no idea. But I got this from saying by Mahatma Gandhi, the best way to find yourself is to lose yourself in the service of others. So if you just think that maybe that's the way the ICS can think about service. We've done short-term missions, but now we're doing specialty-focused missions because if you just focus, like neurosurgery, for example, the one thing in this world is hydrocephalus. If you put a BP shunt, they get infected. Then who else is going to take care of the patient? Whereas if you do a ventriculostomy, it could be successful in 70% of the time now. But you have to buy the equipment, and you have to train neurosurgeons who can do that safely. For urology, for example, for the prostate problem, a lot of men with the prostate problems, they die from infection or renal failure because nobody can take care of their prostate, or they have a Foley catheter going around town, so they stay home or they just die. Whereas if you teach them how to use a different kind of TURP with a plasma button that diminishes blood and also diminishes morbidity, then you can save a lot of people and have them at least have 5 or 7 years of good life without suffering. So these are the things you have to think. It's not just me. I'm a pediatric surgeon. I have my own selfish things that I want to take care of. But the other specialists can do the same. You can teach them how to do differently and make it easier to take care of those patients. And of course, we can bring them over, or you can have exchange programs. where you can bring a resident. It's been done in other universities. They're doing it now, where you can exchange residents or students or wherever come in, and you can train them, or you can go there and at least help in the training. We're doing that now with these programs we have. And I already talked about this, the focus programs. So how do we propagate the idea? We bring residents or fellows when we do these missions. We bring them. I charge them. I charge them right now $2,500, but I'm going to increase the charge to $5,000 per resident or fellow to come with us, so that we can at least provide for their airfare, lodging, and then the rest we use for what we need for the mission. And then you can propagate this, and you can expand the amount of funding you can have, since you can have funding from nonprofits yet. And I had some, for 20 years, we have probably 40 residents that are now doing well on their own, and they're coming back to provide service to other people. Here's one. This is Dr. Sturr, who is initially he's from Germany, and he finished pediatric surgery in France. And then he came to America because he married an American lady, and so she didn't know what to do, so he came to me, and I brought him to a local hospital, and then he wanted to rotate with me, and I said, no. What do you want to do when you grow up? He said he wants to be a pediatric surgeon, so I sent him to Cincinnati Children's Medical Center instead, because the chairman then was also my prodigy. He was a medical student when he first decided to be a pediatric surgeon. And then they stole him away from the local hospital, and he finished in University of Cincinnati, and then he went to Children's Hospital in Washington, D.C. He's now program director in Oakland. So he's now back to being a pediatric surgeon. He's coming back to Honduras with me sometime soon to do other things. Here's Dr. Stauffer from Oregon. I think maybe John knows that. He's also he's a general surgeon. Dr. Torasi is a thoracic surgeon now in Miami. And this is my newest prodigy, Dr. Kaufman. He is when he came 2 missions, then he found out how beautiful pediatric surgery can be, so he got encouraged. Now he's in Hopkins program in Florida as a fellow. So he'll be going to pediatric. I have another one who is a Japanese fellow, Dr. Shin Miyata, who is going to be the fellow of pediatric surgery in Montreal. And he didn't even speak any English when he first came. But he eventually, and he wanted to be a pediatric surgeon, so he became a chief resident at the University of Maryland. He learned English from watching television. But he was smart. So he's going to be a fellow in Montreal Children's Hospital. This is another new prodigy, second-year resident. He was ready to quit surgery. He was ready to quit because he said, I couldn't take it anymore. Then he came to a mission with us to the Philippines, and then he changed his mind. He said, this is really what I want to be, a surgeon now. He's going to be our chief resident this year because of that experience. Few more residents. This lady is a liver transplant surgeon in Montreal. Came twice. She's a breast surgeon. This is a plastic surgeon. This is the wife. He's a general surgeon. So what are the basic needs when you do a safe surgical mission? Of course, you need a functioning OR somehow, and most often you don't have that. You need PACU, you need oxygen, and you need post-op care, nursing staff, blood bank. You need all the things that we normally use every day. Sometimes they don't have that. This is why it's important that when you decide to go to a certain place, you have somebody go there first. Check it out. Then you make sure you connect with all the people that are in charge of that facility and the government and the medical directors, etc. And then you decide what you need to bring. So we have people who can tell us that. You can do problem solving yourself. That's why you need biomed technicians to come along if possible. You can bring them along because the equipment might be non-functioning at all. This is Dr. Bucks. He's an anesthesiologist who was Mr. MacGyver for us because he knew how to fix things. You get donations from people, but now when you have a little money, you can buy. You don't have to ask donation. I don't want to bring old equipment anymore. We just buy them from eBay. I go to eBay now. We just bought a harmonic scalpel, brand new generator for $3,500 on eBay. I was surprised we could do that. So I don't like to bring any more old equipment. All right. Now we have this new program with Safe Surgery Initiative with UK nonprofit and AmeriCares, which is in Connecticut, and we're going to be distributing 1,000 plus oximeters in the Philippines to 330 hospitals. They just started the program as of last week. And they gave us the money. They got this. And I have people on the ground who are doing this, distributing this. You can do the same thing in Sri Lanka or wherever you want to go. You just tell me so I can tell you how to do that. Very important. And then I have a young man, Dr. Tapia. He's from Texas. He creates these kits, these anesthesia kits. It's like manna from heaven for people when we give it to them, because that's everything you need to do, to know, to have, to resuscitate somebody. And he's just a young man, just finished, and he uses his own money. And then he gives it to us. We're going to be distributing 1,000 of these kits in the Philippines, and I've been distributing to other countries that we go to. We have a warehouse, and I have volunteers in the warehouse, and they get prepared for any mission, or we ship them, or whatever we have to do. And then there's another warehouse this is a warehouse in the Philippines, and we have all these boxes that arrive there. And then we have volunteers also who can look at the boxes, and then they would get what they need for a certain mission. And other missions come in and ask for the help, so if we have extras, we give it to them. And then once we get to the place, we arrive with all this, and we have people pick us up, trucks, or whatever they have. You've heard that, you've seen that. She's laughing because you've seen it. And then, fortunately, we have a bus sometimes. Sometimes you don't have a bus. Sometimes you ride on the back of a pickup truck. But you can see, you remember Dr. Amiri. There's Dr. Ranjan. Is he here? There he is. This was our last mission in Honduras with Dr. Ranjan and Dr. Amiri. And he didn't see this one. This one, the year before, Dr. Ranjan, we had soldiers guard us in Honduras. And then I have Dr. Amir try to wrestle the gun from this guy, and he couldn't do it. So what I do is, instead of having Dr. Amiri guard us, I get a nun. She has been going with us for 8 years because she does miracles. She does. I'll tell you another story about her sometime. And then they greet us in wherever we are. Sometimes Rotary clubs, Lions clubs. You have coordination from people on the ground. And I'm showing this. This is our Honduran mission. Again, you can see Dr. Ranjan there because he's tall. And this is Nigeria. This was in November. You can see a whole bunch of people there. And this is what they look like in the room. That's my wife. Sometimes you see all this. These are donated items. And here's the anesthesia machine we saw in one place. You can see, I don't know how they do it, but in India, we bang this to allow the flow of the sevoflurane. We have to bang the machine. to get the flow to go through. So it was challenging. You've seen this machine, haven't you? And this, what we do now, we have portable machine. That's my wife. The portable machine is weigh less than 50 pounds. You can carry this in the jungle because you don't need electricity. All you need is gas connected. And then you can have sevoflurane in this machine. No need for electricity. That's the beauty of this machine. Okay? And we just bring this in a suitcase. And you can go anywhere you want to go.
We're at 20 minutes, love.
Okay, I'm almost done. We got Pyxis, you can see. You've heard that. Sterilizing, wow. You can see there's hardly any room for sterilization. These are similar everywhere you go. I don't know how we can sterilize anything. Then we use chemicals, but that's no good anymore. So we use, we can get portable autoclaves now, and you can sterilize it within half hour. And I have volunteer nurses. So far, we have done 10,000 procedures in 7 countries. These are the sample cases. So like I said, if you want to do thyroids to the Philippines, your hernias, GYN, whatever, and Thailand, India.
Dr. Alvear, I think time is over. Time is over.
Yes, okay, thank you. And I just want to give you the conclusion. Final. This is a very difficult lecture because we have so many things we have done, and all I wanted to say is that the ICS can become the umbrella for all these missions, and we can train residents both from the U.S. and locally, and we can have good relationship with other hospitals, facilities, and doctors throughout the world. Thank you.
Thank you very much, Dr. Alvear, and we do appreciate the noble mission of the World Surgical Foundation. Thank you.
Thank you.